Now, moving to the clinical examination of a case of maxillary midline diastema. Obviously, the clinical examination, the first thing you will check is the blench test, because the most common causes of the midline diastema are the frenum and mesodens. So, in the examination, first you will rule out these causes. You will lift the upper lip and you will see the extension of the labial frenum. Is it extended up to incisive papilla or is it extending palatally? Then this is a sign that the frenum is extending. Then you will see the thickness of the tissue and you will see the whitish appearance of the frenum in the clinical examination. After the blench test, you will look for the palpation. In the palpation, you will see any bulge, for example, the unerupted mesodens. The mesodens is supernumerated between the roots of the sentinel incisors, can be palpated if it is more labially. So you will look for the mesodens palpation. Obviously, it is confirmed diagnosis by the radiological examination, but this is a protocol to palpate the area of the gap between the sentinel incisors to look for the mesodens. Third, you will see the mobility of the sentinel incisors, because mobility in some extent give you a sign for how much the root is in the bone. So in the case of pathological tooth migration, you will see a slightly greater mobility as compared to the normal patient, and increased mobility and increased pocket depth. The gingival margins below the cemental junction on the examination gives the sign of the pathological tooth migration. Then in the examination, you will carefully see the amount of the overjet and overbite. This is critically important to assess the overjet as well as the overbite, because the morphology of the sentinel incisor is like this, that near the incisal edge it is more thinner, but near the cingulum plateau, as we go more apically, the thickness of the sentinel incisors increase. And if you have you are having the overjet and overbite, in which you cannot retract the upper labial segment to correct the diastema. So this information has to be noted at the time of the clinical examination, that what is the amount of the overjet and overbite. If you have a very less overjet and you have increased overbite, then at the time of the retraction of the upper labial segment, at the time the diastema cloyia, the lower incisor will start hitting the upper sentinel incisors and may resist the diastema cloyia. So amount of the overjet, overbite, and especially the trauma-form cloyia. The fourth thing that's more important is to have to assess that trauma-form cloyia. If you see on the articulating paper that the lower incisors is hitting the upper sentinel incisors, and on the hitting of the upper sentinel incisors, then it's mean that you have to treat the lower arch definitely to eliminate the resistance, so you can retract the upper labial segment to correct the diastema. Actually, the diastema can be closed by the retraction of the upper labial segment and the mesial movement of the upper sentinel incisors. The amount of the overjet, overbite, and especially trauma from the cloyia, where is exactly the lower incisors hitting the upper sentinel incisors, is critically important, that this will eliminate the chances and possibility of the retraction of the upper labial segment. Then you definitely have to move the sentinel incisor mesially in order to close the space, because the overjet or increased overbite may not allow you to retract the upper labial segment. So let's summarize this. And in the clinical examination, you will first do the blench test. So do the labial frenum, you will do the palpation of the area to see any mesodens or it is palpating or not. You will see the mobility of the sentinel incisors, you will see the pocket depth, or you will assess where exactly is the gingival margins with reference to the cemental labial junction. You will assess the overjet, overbite, and you will see if the lower incisors are hitting the upper sentinel incisors or not, because this information that we gain from the clinical examination is critically important when we are planning the case for the treatment planning and how exactly we're going to close that space.